This How I Do It video is on contrast-enhanced ultrasound of the cirrhotic liver. It is produced in the ultrasound department at the University of Calgary. CEUS can accurately diagnose benign and malignant nodules in a cirrhotic liver on the basis of real-time dynamic imaging and high contrast sensitivity. CEUS is appropriate for evaluation of nodules from surveillance, indeterminate following CT or MR scan, and for guidance and diagnosis in the post-treatment liver. In addition to the investigator, additional personnel such as a nurse or research aide is required to start an IV, inject the contrast, perform patient charting, and remove the IV once the exam is completed. Standard intravenous equipment includes the tourniquet, 22 or 24 gauge catheter, 3-way stopcock, short extension tubing, a small syringe for contrast agent, and a 5 milliliter saline flush. In Canada, the approved contrast agent is Definity from Lantheus Medical Imaging in Massachusetts. Although slight differences in volume and preparation may be encountered with different microbubble contrast agents of the same family, fundamental CEUS technique remains the same. The perfluorocarbon microbubble of Definity is activated by use of a Vial Mixer. After agitation for 45 seconds, the volume of contrast increases from 1.2 to 1.8 milliliters and turns a milky white color. The microbubbles are stable for the duration of the procedure. The performance of CEUS requires specialized software now available on virtually all high-end ultrasound equipment. The technique is performed with a low mechanical index setting, which induces a stable, non-disruptive oscillation of the microbubble. Image display requires a visible timer for documentation of vascular changes starting at time 0, corresponding with the contrast injection at the saline flush. In addition, dual monitor display, as shown here, is essential for correlation of the low mechanical index grayscale image on the left and the CEUS image on the right to allow for correct localization of enhancement or washout with the baseline nodule. This is an example of a patient at risk for HCC with a focal echogenic nodule found on surveillance ultrasound. At time 0, pulse inversion technique has suppressed the echo from background liver, and the image appears black for several seconds prior to contrast arrival. The contrast image, comprised solely of microbubble information, shows that at 10 seconds the nodule is hypervascular relative to background liver with weak washout by 2.5 minutes. This is the classic enhancement pattern of HCC. Real-time scanning of this nodule shows arterial hypervascularity. Video recording of the wash-in of contrast is performed from visualization of the first bubble in the field of view to peak arterial enhancement for documentation. Subsequently, intermittent scanning is performed every 30 seconds to assess for washout. To show the value of CEUS for evaluation of nodules found on surveillance ultrasound, we will look at two similar risk patients for HCC. The first is a 55-year-old male with a small superficial hypoechoic nodule marked by the arrow. CEUS shows a hypervascular nodule with weak washout at 5 minutes, consistent with HCC. This study facilitates performance of CT or MR scan for staging prior to initiation of therapy. The second patient has a similar nodule demonstrating arterial hypervascularity. However, this nodule shows rapid peripheral puddling with centripetal filling within seconds, classic for a flash-filling hemangioma. There is sustained enhancement at 3 minutes. This patient may return to regular surveillance and no further investigation is required at this time. Dynamic real-time capability allows for characterization of benign nodules on the basis of their arterial phase filling pattern. The real-time assessment of CEUS is also helpful when there is concern regarding mistiming of the contrast bolus on CT or MR. This arterial phase CT scan shows the majority of the contrast bolus within the aorta and celiac axis, likely imaged too early. No mass is seen in the arterial phase. A faint hypoattenuating mass is seen in the portal venous phase, making the scan indeterminate. Subsequent referral for CEUS shows a nodule with hypervascularity and washout by 3.5 minutes, corresponding with the CT abnormality. The mass is biopsy-proven, well-differentiated HCC. A frequent observation on CT and MR scan is that of arterial phase hypervascular foci with no washout. This raises the possibility of arterioportal vascular shunts, or the variant of HCC with no washout. On review of the pre-contrast MR images, no corresponding baseline nodule is demonstrated. CEUS can resolve vascular shunts from CT and MR. In this case, baseline ultrasound does not show a corresponding nodule, and there are no hypervascular nodules in the arterial phase. Portal venous sweeps are performed showing no suspicious washout. CEUS confirms the presence of pseudolesions representing vascular shunts. This is further confirmed by resolution of these findings on subsequent MR scan performed 6 months later. This patient shows similar findings of multiple foci of arterial hypervascularity, one of which is shown here, but no corresponding washout is seen in the portal venous or delayed phases. Ultrasound demonstrates the presence of a baseline nodule corresponding with the abnormality on MR. CEUS shows arterial phase hypervascularity with isovascularity at 1.5 minutes and washout at 3.5 minutes. CEUS confirms the diagnosis of HCC. Hepatocarcinogenesis occurs in a stepwise process from regenerative nodule to dysplastic nodule to HCC. This is accompanied by vascular changes with loss of the normal hepatic arterial and portal venous blood supply with simultaneous neoangiogenesis. This accounts for the variations of enhancement patterns of cirrhotic nodules. This 51-year-old patient with primary sclerosing cholangitis shows a dominant nodule in segment 5. The nodule is isovascular relative to liver parenchyma in the arterial phase. This nodule remains isovascular in the portal venous and delayed phases and is consistent with a regenerative nodule. Another patient with a dominant nodule on surveillance ultrasound shows avascularity of the nodule in the arterial phase on CEUS. This nodule becomes isovascular in the portal venous and delayed phases, most consistent with a dysplastic nodule. Our personal experience suggests this enhancement pattern highly overlaps with well-differentiated HCC, necessitating either biopsy or careful short-interval surveillance. An important consideration in this patient population is the differentiation of intrahepatic cholangiocarcinoma and HCC. In this 67-year-old patient with hepatitis C, the first examination of a nodule shows progressive peripheral enhancement on CT. On MR, the mass demonstrates rim enhancement in the arterial phase with subtle progressive central enhancement in the portal venous and delayed phases. Although well described on both modalities, the diagnosis was indeterminate. Subsequent referral for CEUS shows rim enhancement and rapid washout, two malignant features that are very atypical for HCC. This was biopsy-proven cholangiocarcinoma. Rapid washout before 1 minute or black punched-out washout are features suggestive of a non-hepatocyte malignancy and warrants further investigation. Further, discordance between enhancement on CEUS and CT or MR is virtually always present with cholangiocarcinoma. Lastly, we show a very compelling case of an occult nodule on CT and MR scan. Surveillance ultrasound identifies a nodule in segment 5. CEUS of the nodule shows arterial hypervascularity. The nodule demonstrates a classic enhancement pattern of HCC. Subsequent MR shows no corresponding nodule in segment 5. The patient goes on to have another MR and CT scan also showing no nodule. At 6 months, MR imaging with a hepatobiliary contrast agent Primavist was performed. This exam shows no mass in the arterial or portal venous phase. The nodule only becomes apparent on the delayed phase, and this was biopsy-proven HCC. In this How I Do It presentation, we have attempted to show the technique and spectrum of contributions of CEUS in the multimodality imaging of nodules in a cirrhotic liver.